So if you remember, those of you who've been able to see the first session, it was called Getting to Grips with Evidence Synthesis. So we've called this one Tightening Your Grasp of Evidence Synthesis. So there's going to be an element of reinforcement. So just rehearsing some of the things that we briefly mentioned last time, but we're going to move into some of the new areas as well to extend our learning. And a reminder that I'm Andrew and my email's there, and I'm joined today on the presentation with Duncan, and his email's also on the slides. And we will send the slides round afterwards for your entertainment, if that's the word. So a reminder, this is the second of 2 linked sessions. Don't worry too much if you weren't able to make the first one. We do have a recording of that, and again, Katie will give you details of that if you weren't able to make the first session. But for a number of years now, in fact, we're into our 8th year, we've been delivering research summaries to the National Institute of Health Research. And so we run 2 evidence synthesis centres here in Sheffield, one for public health and the other for health services. And so what we're doing is picking up on different types of projects to give you an idea of the variety and choices that we have when we're doing the work for the funder. And so we're hoping to help you understand a little bit more about what is going on at our centre, help you with the terminology so that when you attend the meetings that you feel more comfortable. An opportunity to ask questions that perhaps you wouldn't want to ask in the flow of the meeting, but obviously, you're always welcome to answer questions, but you might feel more comfortable during this training session. And also, it's an opportunity to build more long-standing partnerships. So as well as the program of work that we do together, we as researchers do put in other applications, and these may be of interest to you on a one-by-one basis as well. So it's an opportunity to develop those ways of working and to feed into the funding applications so that the public's money is spent more wisely and sees better return on investment. But obviously we are benefiting, so we're the 3rd and 4th members of the team to present to you. You previously had Fiona and Sue, that equipping you with knowledge about the process helps us helps you to challenge us so that we don't make assumptions that maybe lead us in the wrong direction. Hopefully it also gets a discussion going and getting rid of any terminology that can act as a barrier means that we're not doing what doctors and lawyers are often accused of doing, which is speaking in their own specialist language. So we don't want to be speaking the language of research. We want to be speaking the language of public engagement in research. So what are we going to be covering today? Well, we're going to add to the toolbox that you already had open for you by Sue and Fiona, 2 more types of review, a rapid review and a realist review. So last time you were introduced to the systematic review, and the systematic review is very much the staple of health research in this country and in many countries. But rapid reviews and realist reviews offer more strings to our bow, and we'll describe those briefly in a minute. We're also going to describe how the scope of a review is decided, and then Duncan is going to show you the various opportunities throughout the review process for making sure that the public voice, or more correctly, public voices, are heard throughout the review process. And then we're going to just have a brief discussion with you about different ways of getting the message or findings from our research out to the public, and inviting your feedback and input on your preferences for different methods of doing that. So just building on what was covered last time, our job is funded by the NIHR, the acronym explained in the top there, to carry out what are called evidence reviews. And those evidence reviews, they try to bring together as complete a picture of the research that's gone on, either in this country or worldwide, depending on the scope, and summarizing it so that we can see the main messages, the main implications of that research for the UK health and social care user. Previously, Fiona and Sue introduced you to systematic reviews. These have a very formalized process of searching and then analyzing the literature and summarizing it in a ready and easable way. But as they say in adverts, other review types are also available. We just want to give you a hint of what those might look like as well, so that if we present a different review type to you at a meeting, you at least recognize some of its characteristics. So if you look on the left-hand side here, you'll see a fairly linear process, and this is very close to the sort of reviews that Fiona and Sue were describing for you. And all we want you to get from the right-hand side, we don't expect you to follow all the arrows. There's more arrows there than Custer's Last Stand, I think. But we don't expect you to follow that whole process. But the take-home message is that our reviews are often a lot more complex than the linear process that is the default, the starting position. So here we have a review that we did, and many of you contributed to, in fact, that we were asked to look at reasons why older people attended accident and emergency services when those attendances weren't scheduled or planned. Obviously, a large number of older people have what are called, and the first jargon of the day, ambulatory care sensitive conditions. And what they mean is that they are people who can typically walk into an A&E department, but they have conditions that some of you indeed may have, COPD or other forms of lung disease, asthma, diabetes, those sort of conditions. And perhaps not unfamiliar for the health service, unfortunately, the people who attend don't always need, and the people who need don't always attend. And so what we were asked to do was to look at what makes people attend and why. So, for example, why might someone be reluctant to phone an ambulance, say, at a second time of asking, and might that be shaped by their experience of the first time of asking? And so this type of review that looks at what makes people respond the way that they do, so why people behave the way they do when using services, that is called a realist review. So we're trying to, if you like, open the box and find out, why are people behaving in that particular way? And the argument, of course, is if we can understand that, then it helps us plan the services and make sure that services are more appropriate. So you might ask, well, you have the nice simple version from Sue and Fiona on the left-hand side in the first session. Why do we have to make things so complicated? That's because if you think about it, a policymaker, whether they be a member of your local trust board or whether they be on a national level, they don't only want to know what works, but they also want to know why it works. They also want to know for whom it works, because interventions we know don't always work for everybody, and in what circumstances. So how can you make things work better? How can you get the best bangs for your buck, to use that dreadful American expression? So how can you get the best value for money? Of course, decision makers, although we tend to think of them working in statistics and averages, they don't really want to know what works on average. It's often been said that an average means that half of people are getting more than they want and half the people are getting less than they want. So averages aren't helpful in terms of us as individuals. So none of us would like to be described as average, although I have been in my time. So they want to know who do the interventions work better for, or indeed who do they not work as well for. And if you think about that, if money is limited, then being able to target at the people most likely to benefit from a particular intervention and hopefully offer alternatives for those who are unlikely to benefit is a wise spending of the public purse. And then the other pressure that you will all be aware of, particularly in the COVID situation, is that policymakers often want to have the science or the results quicker than we could manage from a standard systematic review. And you were introduced to the steps of a review to show you what a systematic process it is, careful stages to identify the data, to pull it all together and learn the lessons from it. And we'll be returning to this process shortly with Duncan. But not surprisingly, when you have a limited window of opportunity to try and make a decision, decision makers often want to try and speed the whole process up. So our team is involved in accelerated reviews, reviews that are sped up. And that might mean that we assign more staff to it, that we use computers to help speed up the process. Or the other thing we might do is take shortcuts. So we make a careful judgment to say, is the gain in terms of speed of getting a result, does it outweigh the loss in terms of the completeness or certainty of the result? And so if we feel that we can deliver a good enough answer in a shorter period of time to meet the policy window, then we'll do that as well. And so some of the things you'll hear in the various meetings that you'll be attending in the future, and no doubt in the past, will be that we might, for example, search fewer databases. So instead of searching, say, 5 or 6 databases, we may target 3 databases to try and find the information we want. We may, as researchers, spend less time looking at each included paper, taking less data out of each paper to just get the main take-home findings. And as I mentioned, we might also use computers to help us spot the most likely articles to be of benefit. And we just wanted to give you a little bit of a profile of how our centre works in terms of these research topics. It would be nice if we were able to decide those topics for ourselves and work with you so that you helped us decide those. But we're actually coming in a little bit further down the line. So the funders, they give us questions that have been submitted perhaps by professional associations, by patient groups, patients with a particular condition or who are familiar with a particular situation, or questions that have arisen from previous research as research gaps. And of course, then there's the wild cards, if you like, the burning topical issues, because who would have would have predicted that there was going to be an interest in airborne viruses 19 months ago. So those questions are prioritized, and then they're divided between ourselves and our sister centre in Exeter. And so the question is fixed in terms of the topic area, but where we have the room for the wriggle room, if you like, the room for negotiation is in involving yourselves. We need you to help us decide, first of all, if the version of the question that we've brought with us from the funders makes sense to you as members of the public. We want you to think through what some of the issues might be. Because, for example, it might be that you can identify some sort of undesirable way that the public would have to behave in order to benefit from the intervention, and that might put them off. So you can help us with that. You might be able to help us spot things that we as researchers, normal human beings, despite appearances, we might have missed them, or the funders might have missed them. But you, with your experience of health services and your experience of life, may throw something into the mix that we've overlooked, and therefore make the science better and more useful. And also you can help us in feeding back the understanding of the brief to the funders. So we make sure that they get a more complete picture than they would if they just used us as individuals. And all of this goes to shape the review protocol, which Duncan will be mentioning shortly. So there's quite a bit there for you to think of, but I'm just going to finish with my last slide before handing over to Duncan. Here, as well as working with you on making sure that the question is meaningful, we also need to decide what you might call the logistics of the questions, to make sure that it can be done in the time given, to make sure that it's useful, and to make sure that we have the researcher time available to do it. So the sort of decisions you may find us having made, or indeed inviting you to help us with, we may decide how many years we need to go back. So something might be more recent, or in fact there might be a long history of trying to tackle a particular problem, and we might benefit from going back to older research. We also have to decide which other countries may be relevant. Sometimes we might be interested only in UK research. In other cases, we might go for what you might call the Anglophone countries, the countries with a similar health service to our own, like Canada and United States and Ireland and New Zealand. Or on other occasions, we might go to high-income countries, which despite appearances includes Britain, or indeed we might look at anything that's been tried anywhere in the world. We also have to decide which population groups are in or out, so where there's going to be an age cutoff, or whether we want to focus on a particular ethnic group because that service or that health condition is particularly important for them, or indeed sometimes they may be gender issues, or anything really to do with possible areas of inequality that need to be ironed out by the health service. We need to decide which settings of care are in or out. So should we just be focusing on primary care, or what goes on in hospitals? Which types of care are similar or different? So what makes sense to lump together? And all of these decisions that are made by the review team, but informed by yourselves, help to shape the review protocol. And so just to conclude with one of the projects that we did fairly early on in the contract. So most of us now are familiar with Professor Chris Whitty. He's almost become a household star. But before him, there was another chief medical officer who wasn't so high profile, but he asked us through the NIHR to investigate what are called group clinics, which are sessions for groups of patients who share the same condition, where groups of health professionals may see them as a group, as opposed to the one-to-one appointment that we're probably most familiar with. And so he was asking the question, would they work in the UK? When we did our research, we found that UK patients have a very strong expectation of a one-to-one appointment. And so even if you offer people in the UK a group appointment, they still expected an opportunity to be able to ask questions privately. And so in essence, they didn't want an either or, they wanted to have both to improve their knowledge of a condition. And so what's happening with this, because obviously it would be very expensive to see everyone in a group and individually as well, is that research is being done to target those groups where a group approach will be particularly beneficial. And for example, in Oxford, it's been shown that it's particularly helpful with youths with diabetes, because they can therefore provide some support to each other, but also learn together with the health professionals. So just to summarize my introductory bit here, you were shown by Sue and Fiona last time that a systematic review is very useful because it helps you to look in a systematic way at what works. We've added two more types of review to the mix: the realist review, that helps us get under the skin of the users by working out what works for whom, under what circumstances, which services are likely to be well accepted and which ones are likely to be resisted. And then the other type was a rapid review, which was starting from the template of a systematic review, but either speeding up the process, perhaps by throwing more researchers at it to get it done quicker, or making sensible shortcuts so that we can deliver an answer in a timely way. And just a reminder of what we said about the process, that we and you, we don't choose our topics. They are selected by a prioritization committee, and that does have patient involvement. So it's not that the patient voice isn't heard at that stage, but it's a different group. But we and you can shape each topic, so we have a lot of say in how we interpret the topic and can shape how we respond to it and the findings. And Duncan's going to mention two of the opportunities for shaping that you're directly involved in, namely the protocol and the plain language summaries. So I'm going to pause there. Sue, I don't know whether, do you think we should stop for questions here or hand on to
I think it's
Duncan?
probably easiest if you go on through, and then we'll take questions at the end, if that's okay.
For technical reasons, if you don't mind that, everybody, just because if we don't show the slides, we might lose them by the end of the session. So I'm going to hand over to Duncan then for the next part of the program, and he's going to start with how else can I get involved.
Thanks, Andrew. Will you move the slides on as I sort of get to the next one? Yeah, okay. Thanks. Hello, everyone, and apologies in advance if this presentation sounds a bit scripted. I didn't have time enough to prepare for it to sound spontaneous, so here goes anyway. The table that you can see up there on the slide highlights typical examples of public and patient involvement at different stages of an evidence review. I think this is general enough to apply to the different types of reviews that Andrew was talking about. The way things typically happen at present is that involvement is concentrated at the beginning and end of the process, with a phase in the middle where the review team largely get on with technical tasks until the emerging findings are judged fit for presentation and interpretation. Next slide, please, Andrew. So it's now standard practice in publicly funded health research for patients and the public to be involved in prioritising research topics, reviewing funding bids, and helping to develop new bids. I'm sure many of you have been involved in some or all of those processes. Many research bids include one or more patient and public members in the research team as co-applicants, and this means funding for their involvement is included in the budget if the bid is successful. Indeed, I've recently managed to lead a bid with a public co-applicant from this very group. Next slide. Thanks, Andrew. When it comes to developing the review protocol, and it should be clear that all types of review, again, the protocol is just as important for a rapid review or realist review as it is for a standard systematic review. You, as a patient and public members, are likely to be able to help the review team to focus the review question, to choose the most relevant outcomes to prioritise, and to write a clear, plain English summary. You may be able to use your lived experience of a condition or health service that the researchers lack. And you may have valuable networks and contacts that the review team can tap into. Next one. So literature searching is the first technical phase of an evidence review, where there's generally been less patient and public involvement overall. It is generally carried out by trained information specialists who are experts at searching online databases and other sources thoroughly and efficiently. Lists of search terms, often known as referred to as search strategies, may certainly look daunting. But if you are interested, there is definitely potential for involvement in reviewing draft searches and identifying terms the researchers may have overlooked. Next one. The next, thanks to Sue for this slide of an extraction that's going on there. I'm not quite, as we were discussing this morning, exactly what's being extracted is unclear, but the next technical stage is data extraction, identifying the important features and results of each included study and summarising them in words, tables and graphics. Identifying the right data is obviously vital for reaching appropriate conclusions. If the process is not done efficiently, the review team, they find themselves having to go back and look for data that wasn't extracted in the first place because it wasn't realised it was important. Next one. Data extraction can be carried out using various different types of software. The example shown here is from our current project looking at investigation of memory problems. The software we use is called EpiReviewer. It allows us to store all the information we need in one place, including full text copies of the studies included in the review. Let's see, the menu, yeah. Oh, sorry, Andrew. Can you go back? Yeah. The menu on the left lists the data to be extracted for each study. And extracting the data may involve choosing the most appropriate answer to a question, sort of tick box or multiple choice. And it may also involve either that or writing a short piece of text summarising something about the study. Extracted data can then be searched and used to put together tables summarising included studies, and that can be done automatically with software like EpiReviewer. Involvement of patients and the public in technical processes like data extraction is not unknown, especially where review teams specialise in a particular topic area over a number of years. This type of involvement seems to move from what might be called standard PPI to what is sometimes called a peer researcher model. Yeah, the next one is synthesis. So last but not least, synthesis involves looking across the review findings as a whole to identify patterns and contradictions in the data. For example, do studies in the UK and USA show similar results? Is there a difference between better and worse quality studies? Reviews aim to be transparent in the way they bring together the evidence and use it to draw conclusions, but barriers to doing this include the use of statistical methods that are hard for non-statisticians, including other reviewers often, to understand, and the almost inevitable use of some jargon in describing and reporting the findings. Again, peer researchers may have a role to play. Next one. We're now going to finish by talking a bit more about communication of review findings. I'm handing over to Andrew again for this section.
Yeah, because that's a slight change of angles, Sue, and we want our participants to have an opportunity to ask questions. Perhaps we'll just pause it here. But as I can't see the screens at the moment, would you mind sort of just asking for questions and inviting hands for us, Sue?
Yeah. Do you want me to manage hands and comments? Yeah, absolutely. Yeah. So Margaret, did you want to come in there?
Yes, there were a couple of things. There was one that I missed completely. I'm sorry, Duncan. It was the name of the software. It was the slide about memory services. What was the name?
The software is called EpiReviewer, Margaret.
I cannot get that. I wonder if you can put it in the chat for me.
Yeah, sure. Yeah, it's EPPI, EPPI.
Yeah.
And then the word reviewer, yeah.
Okay, that was my question.
Yeah, fabulous, thank you.
So the other thing was about the word dry. It kind of has very negative connotations to it. I often use the word abstract when I talk about evidence synthesis, which I think is a better word because it doesn't have that negative connotation of being boring. And personally, I don't think data extraction's boring at all. I quite like that side of it. So they were just the two things I had to say, and they were both good presentations. Thank you.
Yeah, thank you, Margaret.
Great to hear that, Margaret. Yeah. It's great to hear that. Thank you.
Did anybody else want to know any more about the kind of different types of reviews that Andrew and Duncan have talked about? So sort of the realist or the rapid review. Are people come across those before? Are people sort of wanting to know any more about that? I'm not seeing any hands. Yeah, are people happy with? Yep. Yeah, Camille, did you want to come in there?
I just wanted to ask about realist review, because I think I've heard the term realist evaluation as a research method. Could you explain what it is?
Yes, I'll give you the very brief version, but I mean, you've made a great connection there, because if you can imagine that when you go into the community and do some research, then that's what we call primary research. But when we do a literature-based version in our offices, or at the moment in our homes, then that's what's called secondary research or synthesis. And so a lot of these terms have equivalents in the primary research and in the literature base, the secondary research. So realist evaluation, that you've just used those terms, though that is the term for doing what we do, but when you're doing it in the community with live primary research. And we do the version of it which is called realist review or realist synthesis, which is what you do using the same methods, but based on the literature. And very briefly, the first thing that you try and do is try and work out, and it could be through asking lots of people, or it could be through looking through service documents or through articles. You try and find out what the particular health intervention, the particular treatment or health program is trying to achieve. So you sort of frame what is trying to be achieved, what the important outcomes are from that. And then you take a step back from the intervention to say, well, how does the intervention have its effect? So how do people respond to it? So in the example I gave earlier, you can imagine that when people have a form of treatment, which is, or a form of program, if you like, where they can pick up a phone and dial 999, then what actually triggers someone to dial 999? Well, obviously, one thing might be anxiety. Another thing might be that people are having symptoms that they've never had before, so they've got no precedent, no mental frame to deal with. And so we come up with a list of those sort of explanations. What are those circumstances that might trigger someone to use that particular service? And it could be any service, a diabetes service, a nurse taking blood, whatever it might be. But we try and work out the different reactions people might have and why they might have them. And then we can help design the service to try and meet that need. And so the realist evaluation that you're talking about would be similarly going into people, asking patients, asking health professionals, why do you think this service works? Why do you think it's good for the community to do this, to deliver this service, and then to find the data to see if what people are expecting to happen is actually happening in practice.
Okay, thank you, Andrew.
Yeah, fantastic. Yeah, I think it's something that is growing in popularity, isn't it? I'm sure you'll correct me if I'm wrong, Andrew, but I think you're probably likely to see more and more of sort of applications for grant funding for realist reviews.
Absolutely. And the thing that's really interesting for us as a group is that the Health Service and Delivery Research Group is the one that we're funded by, is one of those most keen in it. So it's good that we're ahead of the game, if you like.
Yeah. So Margaret's asked a question. Do you think a rapid review runs the risk of missing something important? Which is a good question.
Yeah, I'll hand over to Duncan on that one. If he's still with us.
I think your mic's still. Oh, there you go.
Well, I was going to hand back to Andrew on the grounds of him being a leading expert on rapid reviews and rapid review methodology, whereas I'm more of a conventional person myself who came to this later in life.
Okay, right.
It is. I mean, you obviously
that's nice offload. Yes.
You certainly have to be aware of that risk. Yes.
Yeah.
Guarding against it. Yeah.
Yeah, I think, Margaret, the point is that you try and estimate what those chances are, so that you can build that amount of uncertainty. So if it's a very minor risk of missing something important, then you can frame the conclusions of your report appropriately. But if it's a major risk, then obviously, as you're implying, we have a real duty to make that clear. But as we've seen with, for example, some of the decisions being made around COVID over the last few months, very often having some information in time is actually quite influential in a decision, even though ideally we'd like more information given more time.
Yeah. So Margaret's saying, yeah, that's exactly what she was thinking of, COVID. Yeah. So I think that has sort of nicely shown this kind of balance between kind of thoroughness and rapidity, and sort of where you actually, you know, fit the balance with that. Yeah, Duncan, did you want to come in?
Well, just to add that probably a lot of poor quality rapid reviews have been done, but they still call themselves systematic reviews, and that's one of the issues, I think. Yeah, and I think certainly, you know, when perhaps as public reviewers, you know, you're looking at applications, it's sort of really helpful to kind of be aware of where those corners have been cut, in order to you know, to reduce the time down, and sort of whether those are kind of fatal flaws or not, really. Yeah, Joyce, so she was asking, is there ever a situation where you would, whoops, it's popped down, whether when you would do one form of review followed by another? So that's a good question.
Yeah, in fact, that's part of our process now, that because what you don't really want when you're spending public money and choosing one topic in preference to spending that same time on another topic, you don't want what are called false starts, do you? You want to be fairly sure that you can start off on a review and have a fairly good chance of being able to provide at least some answer. So increasingly we do more rapid types of review. They're not necessarily always called rapid, but they do tend to be speedier than a systematic review. The two that come to mind are mapping reviews, where you try and make sense of a broad area. So, for example, you might do a mapping review of something like stroke services to see what the different services are that are offered. And then another one that comes before a systematic review that can do is something called a scoping review, which is really more about setting the boundaries, a bit like I was showing you with things like the age of people and the ethnicity and the countries to be included. So to make sensible decisions about where the boundaries go, you do what's called a scoping review to see what the implications are of drawing the boundary, say, in one place, or going wider, going large, as they say in McDonald, or going narrower. So it's a little bit of, if almost like modeling or prototyping, so that you're more likely to get the systematic review right. So it's a bit like a pilot study for those of you who've come across primary research. So a chance to make some important decisions without having too much risk.
Yeah, and I think some of you might have been involved. We actually have done quite a lot of those kind of two-stage mapping to full reviews. And again, as you were saying, that's a real key area where often as public advisors you can help us with. So once we've actually done that initial mapping work, you know, we can actually get some thoughts on where we might want to shine a bit of a brighter light. And again, that's sort of somewhere where I think it, you know, you can have a really helpful input. So we've got Margaret. When's a review followed by a meta-analysis?
Oh, they're really coming out with the technical questions here. Yeah, so we don't, as a centre, and by that I mean the one funded by the NIHR, we don't do many meta-analyses, and that's mainly because of the type of services that we're looking at. But you're absolutely right that of all the reviews that you can possibly do in a systematic way, there is a very small subset where people have measured the same thing in the same way over the same interval. So, for example, say stroke rehabilitation. That number of studies could all have used the same method of stroke rehabilitation. They could have measured outcome at 1 year, and they may have used the Sheffield super duper scale or something like that. And as long as they've all used the same scale, then you can compare those figures and you can treat them as if they're part of one larger study. So a meta-analysis is really an attempt to assume what would be the results if, to get the numbers you need to prove something, instead of using one big study, which of course is very difficult to fund and may not be conclusive, you use lots of little studies. So a meta-analysis is using lots of little studies with sufficient cautions and caveats, but lots of little studies as if they're a big study. And obviously you still have to look at how different they are, but essentially that means that particularly where things have been measured, I think that's probably the easiest thing. So if any of the reviews that Duncan or Sue presents to you at one of the PPI meetings have things that are measurable, you can ask whether we've considered the possibility of meta-analysis. But when it's, for example, how do people react when using accident and emergency services, it's less likely you can answer that with numbers.
Yeah, I was trying to think whether over the whole course of the contract, whether we've actually ever had studies which are sufficiently similar to actually do. I don't remember us ever being able to do one. I don't know. Can you remember? Or I know you wanted to come in, Duncan, as well. I don't know if it's about this or something different. If you want to chip in, do. I don't remember us ever having sufficiently similar outcome measurements to be able to do it, but I could be wrong.
No, the nearest we got was with the group clinics and also with the pediatric cardiology, but I think in both cases the data wasn't sufficiently similar enough, but that was the nearest we got.
Yeah, Duncan, did you want to come in? Your mic's off still.
I was just going to say that obviously meta-analysis is used much more extensively when you're looking at the effectiveness of drugs, and to a lesser extent sort of surgical treatments and things that are more standardised like that. So that's why it's used a lot by NICE.
Yeah, so great question. Thank you, Margaret. Yeah, and great that she's saying it's a terrific explanation, Andrew. So
lovely. Shall I move on with the
yes,
little bit on communication?
If you would, that'd be fabulous. And then we may have a little bit more time at the end.
Great. Well, I can't take any credit for this, but this is our sister centre in Exeter, and they produced this lovely poster which looked at 6 different ways that you might communicate what you found in your reviews. And although it says systematic reviews, they do the same variety of reviews that we do. So we've got 6 there. We've got a straightforward illustration or picture. We've got podcasts, infographics, briefing papers, blogs, and board games. So the first of these, starting on familiar territory, briefing papers, and I just thought it would be helpful just to pause, just to ask people what they think of when they see the term briefing paper, and whether they think they're useful with research findings.
Did anybody want to come in there, or anybody come across them, seen one?
I've come across preprints, and once I knew about them, I thought that seemed a really good way of looking at stuff that was current. Because, I often tell researchers to say, this is the evidence we have, and then I add to date, because there might be something current.
Would you say they're the same or different, Andrew, to these briefing papers?
I think that they're trying to do something similar in the sense that we can't absorb the whole extent of the information, so we're working through a summary of it, and obviously briefing papers is something that we do use in the centre. In fact, we've had input from the PPI reps in terms of the wording of them in some cases. So yeah, I think they're trying to do the same in summary. The one that I've got from the King's Fund there, for example, it says 21-minute read, so it's a way to get up to speed very quickly. So it shares that, but perhaps not in the way we use them necessarily just for the very current stuff, maybe for stuff on a particular topic, I think. So,
and is that different from an abstract?
Yes, because you're trying to do more than inform. You're trying to direct people towards action, I suppose.
Yeah, Anna's done put a great summary in the message box. Briefing papers for a quick summary on a topic. Great,
yeah, absolutely. So this one, for example, instead of having to wade through the whole white paper, then the King's Fund have produced this sort of guide to it. And so we're looking at what we might call competitors. I mean, they're not quite in the same area, but we're looking at people in Canada who do these sort of things and trying to sort of, I was going to say steal, I don't mean that literally, but, you know, borrow and adapt their good techniques and use those to try and communicate our own research. Shall I go on to the next one there? So we're moving into what's called the social media sphere here. Anyone come across a blog before, and how would you describe a blog to someone, a fellow member of the public who hadn't seen one before?
Yeah, I think some people write them actually in this group.
Great. Well, you're the best people, because I've never written a blog. Duncan's written a post, which we've got on the screen here. But so someone like to say how they describe a blog to a fellow member of the public?
So we've got suggestion: an informal commentary on a subject, informal personal view of a topic, blog easy to read, somebody's experience or opinion.
That's great, and I love the way you say informal there. So that's a message that we as a team have to take away from this exchange with you, that you know, the danger is as researchers, everyone puts on a telephone voice, don't they, when speaking to someone posh, and we don't want to put on a formal voice when we're trying to communicate things in this informal context. So that's really helpful feedback. So how have you seen them used effectively? What have you seen them use effectively?
So it's a suggestion, a bit like a pitch, picking out salient points is another good descriptor. Excellent.
Yes. So really being able to help the more prominent stuff sort of show up amongst the rest, so you don't get drowned in information. That's lovely. Thank you ever so much for that. We won't spend a lot of time on illustrations. We've all been seeing those since the age of 3 or whatever, or indeed, you know, familiar with them, signed pictures as well. But I just was going to invite a comment. Can you think of a good example where a picture has helped convey something about research, not necessarily health research, but what made it effective, the use of an illustration or picture?
Yeah, so there's I don't know, Margaret, are you thinking of the illustration that's been on the announcement of James Lind priority setting, or is this going back to the blog again?
Just with the blogs,
yeah.
Quite often that's how they follow up a workshop where they've set a priority and they do a blog on Twitter or something. So pictures, yeah, they can be very powerful. I saw a simple one in a training session, a very similar session to this one, where they used a footpath going to a hospital. And one showed a direct route and the other showed an alternative way, which was much more meandering. And they used that as an example of research and the patient perspective. So the patient wanted the easy access to the hospital and took the different route. And I thought that was a really powerful. I don't know whether I've clicked it or not. If I have, I'll send it to you.
Yeah, that sounds really good. Yeah, there's a suggestion of another blog come through, which I don't know. I don't know if either of you do. No More Surgeons?
Oh, that sounds interesting. Yeah.
Yeah, I don't know, Anna, did you want to say anything about that, or are you happy?
It's a surgeon at James Cook Hospital who's been blogging on their experience of COVID. Is an ICU surgeon, so it's direct from the ICU at James Cook Hospital.
Oh right, that sounds
really
interesting.
well written. Well, I personally think it's really well written. It's very factual.
Yeah.
It's very personable. It's easy to read, but there's a lot of
fantastic. Yeah, no, it does sound good. So there's another comment here. Illustrations can show more clearly a process than a text explanation. So something like the research process. So sort of processes are particularly good. So I don't know if Margaret, you're saying it, that's quite interesting. I'm aware we've only got 4 minutes left.
Okay. I suppose I'll just sort of conclude with this one, and then I'll just mention the last ones. So I just really wanted to see if people were aware of the difference between a picture and an infographic, and again, whether there's any examples of things that they found effective.
I think they're more descriptive, aren't they? I'm thinking of the health plate where it's sectioned off. I can't think of what they call it now. It's like a healthy eating plate, and it's sectioned off into what you can eat. Do you remember?
Oh,
We've all
yes.
seen it. Yeah.
The Change for Life
portion
ones.
plate. That's it. Yeah, portion plate. Yeah.
Mm.
That's because it explains things more to everybody, from people with learning disabilities all the way up to whatever.
That's a really good point about them being inclusive there. Yes, thank you.
So Margaret's saying it's sort of similar to storyboarding, then Stuart's saying that infographics are common in alcohol use.
Yeah, there's close to easy read as you can get without doing easy read, if you see what I mean. They're more of a grown-up easy read, if there's such a thing. Which shouldn't be what I'm saying, because I'm.
No, that's good. Yeah, and they use symbols, don't they? So, for example, they show the number of wine glasses just rather than just having the figure with the number there. So
exactly, yeah.
Great.
And they do it on a lot of cancer infographics as well.
Yeah. Did you want to quickly come back in, Margaret? I think your mic.
Sorry, no, I'm fine, thank you.
No, okay, yeah, sorry, I wasn't sure if that was an old hand up or a new one. That's fine. Yeah. Yeah, no, sorry, Andrew, I'll let you carry on.
Well, yeah, I was just going to say, and the other ones in the repertoire, and it would be really good to talk about these at a future meeting. But podcasts, and obviously because the BBC are quite heavy users of this, they're sort of almost like little regular magazine type items that are in a series, usually linked by theme or by person. And then board games, we haven't done this yet. This is usually, you do this for bigger projects and where you're trying to change behavior, not just present findings. But for example, Exeter have used a pet therapy board game. I don't know how you do pet therapy with snakes and ladders, but I think it would be a lot of loving before you want a snake, I think, but still. So I'm just going to hand over to Duncan for just a very brief summary of the last 2 slides here. And then we'll do some winding up and find your observations. Duncan, microphone.
Thanks, Andrew. Yes, there's another table sort of summarising some of the pros and cons of different types of output, some of which Andrew included in the previous section, and some of which are more conventional ones. So basically, it's fair to say that all these ways of presenting your work have pros and cons, and it's a matter of balancing them out to decide which you think is most suitable. So in general, there's a balance between accessibility, including for people without internet access, for instance, or people with visual impairment or without English as their first language. There's also the time and expense involved in time and expertise involved in producing them, and the likely impact. So, for example, an evidence summary may be fairly easy to produce and make available, but you'd probably only access it if you'd already heard about the research somewhere else. Social media are interactive, but you may end up interacting with trolls if you're not careful, especially if you get into a more controversial area, like I once did a review on, was involved with a review on chronic fatigue syndrome, which is very controversial. Short videos are accessible and potentially ideal for people patients and public to be involved, but they do need some equipment and expertise if they're to look professional. Is there time for the last slide? I think I've more or less covered that one. Thanks, Andrew.
Yeah, that's great. Fabulous. Yeah.
We'll leave this one on, I think.
Yeah. Emphasises the importance of having a communications plan and being prepared to change your approach if circumstances change.
So back to Sue then. Thank you.
Yeah, no, thank you. Yeah, sorry to rush you through that last communications plan, because actually communications plans are really, really important. So we've probably done them a bit of a disservice rushing through, haven't we? So as another comment, that infographics are really useful when explaining to an audience. So a combination of text and images can be really, really useful. But anyway, I'm aware of time, so that's a slide which just really summarises what Andrew and Duncan have covered in the session. So thank you very much to both of you for providing the session today, and thank you everybody for joining us. It's been really great that so many of you were able to tune in today. We are recording this session, so it will be available later for you to have a listen to again, just in case once wasn't enough. So you can go back and revise it again, but also for other members of our groups that aren't able to come today. So thank you all for joining. Katie is going to send out claims forms to people, as we really appreciate, obviously, your involvement in the centre, and sort of are very happy to provide this, very pleased to provide this training as sort of part of your involvement. So Katie will be sending those out. I don't know if Andrew or Duncan, you wanted anything else, or is that...
Well, no, I'd just like to, again, thank you for attending our session, but particularly if you can think further about communication methods and perhaps feed that into future meetings, because that's an area that Duncan and I, well, the whole team would benefit your input from. Thank you.
Right.
Yeah, fantastic. Yeah, so thank you ever so much for joining us, and I hope you have a good rest of the day and don't melt too much from the heat. And we'll look forward to seeing you all soon at another meeting. So thank you everybody, and we'll see you soon.
Bye.
Thanks, Sue.
Thank you.
Yeah,
Bye.
bye now. Bye.
Brilliant.
Bye.
Really good.